Thanks everyone for joining us here today. We apologize for the little bit of a late start. We actually got an early start because we we accidentally pressed the broadcast button too early. Oh, and Maria. Oh, Maria, you're on. Maria's asking for the invite again. Okay, Maria, I'm making you a co-host, so you're like the rest of us. You should be able to then get on okay. Anyway, thanks everyone for joining us. Today we are going to have, originally we thought this might be a short discussion, but we decided there's too much to talk about to make it short. And as you can see, we've got a full room. So thanks everybody for joining us. We will be talking about inpatient status for COVID-19 patients, also where do you put them in the house, how long you keep them there, and what do you do, how do you know when it's time to discharge them. So we have with us Jamie Haering is joining us, as well as John Hall. John is both a physician and a lawyer, you know, and an MBA. He's one of those overachievers, you know, kind of guys I hated in high school. Anyway, and then we also have Marina Farah. She is a longtime hospitalist out in Oregon. Maria Johar has been able to join us, and she is a working physician advisor with Ensemble out of Ohio. Priyanka is Deepak's wife, and she's a physician advisor out of, works with him out of the Dallas area. And then, of course, Deepak, he is the CMO of Aerolib and the CEO of Aerolib Ventures, who is the host. So as you can see, our agenda, we got to figure out how to make this so that I can see the whole presentation as well as the all of this stuff, all the videos. But anyway, so we'll see what happens. So we're learning the room. Anyway, we do want to issue a short disclaimer. That we do want to make clear that the opinions shared in this show, those of our speakers, panelists, are not necessarily representative of their employers. My opinions are, of course, my own and nobody else's, especially not those of Aerolib Ventures. And finally, we're offering these shows for educational purposes only. We're not offering legal advice. But we do our best to provide you with great, accurate, and conservatively considered education for physician advisors and those who work with them. And hopefully we are at least helping to empower all of you in your noble cause of working in healthcare. And it is both noble and sacrificial. And as I say on the screen there, not every hero carries a sword or wears a cape. And if you're on this webinar, as far as I'm concerned, you're a hero. I've been saying that for months anyway, but especially these days. So thanks everybody for the work and the sacrifice that you do. One thing we wanted to remind everybody about is there is a complete comprehensive physician advisor services being offered now by Aerolib that includes case reviews, audits, telehealth utilization, especially for weekends and holidays. That should be a big help to a number of places. All of these shows are in the learning management system that Aerolib makes available, as well as they have a dynamic dashboard for analytics that is pretty significant if you ever go take a demonstration of it. And then Aerolib Cerebral is a new AI-powered regulations research tool, and you're going to see that on the show today. So we're basically introducing that here on the show today. But as I said, we're talking about when is COVID-19 inpatient. And, you know, this is really what we're talking about today is probably the best reason we've been able to come up with in years about why you need a physician advisor now, although we have heard of places laying off physician advisors, and we think that's a serious mistake for a hospital to do that, because just because there's waivers out there doesn't mean that everything is gone. Everything is still an issue. That was an issue before this, and there's going to be more issues after this. So anyway, these are the 3 questions that we'll be discussing. When is inpatient appropriate at presentation? How long do you keep them in-house, and where do you put them? And when do you know it's safe?
Welcome to Zoom. Enter your meeting ID followed by pound.
Oh, who's that? Maybe Jamie. Let me see if I make this.
While we're taking a break, is it a way to
your participant ID followed by pound? Otherwise, just press pound. You have joined the meeting as an attendee and will be muted throughout the meeting.
Oh, that was Maria. I don't know why. Okay. Well, anyway, Maria, you can unmute yourself when you're ready. Okay. So first thing we wanted to do was show everybody this tool, which can be very helpful to you now as well as later. It's a tool that Aerolib created, the Aerolib team, and it's available at theaerolib.com, or you can go to the aerolib.com site, and there is a link at the top there, as I'm showing on the screen, that gets to Cerebral. So Deepak, I'll let you tell everybody about this.
All right. Hey, thank you so much to all the Aerolib panelists as well as all the attendees. You know, this is over the last few weeks, we've all seen what COVID has done. And as physician advisors, we may not be the frontline staff who is being hit, but we are in the back end trying to help hospitals in doing the right thing. One of the questions that our team had thought about is how do we help hospitals in navigating all the things that are coming in. You know, what a usual cycle for regulations is, you know, one comes out every year. I think in the last 20 days, we've seen at least 18 with so many waivers, and I think John will address those and Jamie will address some of those. But the idea was, how do we use this for hospitals for an easy search? So I'd like to thank IBM Watson, Aerolib Ventures and IBM Watson had thought about this about 3 weeks ago, and that was what Aerolib Cerebral is. All the new regulations, as well as the Medicare Processing Manual, as well as regulations that have been released up to day before yesterday, were fed into the AI tool, the Watson Discovery, and it is based on an easy search tool. So there's about 8,000 documents that we have there, and the goal is, you know, if you type in, hey, COVID-19 and telemedicine, it should come out with the right answer. And we've been testing it over the last few weeks. From a back end, we have to train Discovery on what's relevant or not, but it is a free tool, and I think the only thing you need to do is register yourself and start using it. What happens in the background is, you know, the number of questions that people ask help the tool to be more specific in getting the right answer. And over the last few weeks, when we've tested it, most of the questions have revolved around SNF waivers, Medicaid and COVID-19, telemedicine and COVID-19, utilization review and COVID-19. And so it's, you know, when we released this as a soft version a week ago, people were trying to search on what can they do in terms of back-end regulations. And so this is not providing medical advice. This is not providing treatment protocols, but it focuses on regulations only. And Ernie, I think you have a few more slides to go through, but feel free to go on to the website, register yourself, start using it. The information that we are collecting is going to be shared with IBM, and what we're trying to do is, if there's any way Aerolib can help or IBM can help, please reach out to us.
Yeah, that's you go to the aerolib.com site, and there is a registration box. And once you do that, then you will have a login to Cerebral, and you'll be able to start using it right away. And highly encourage people to send in feedback and questions to Aerolib, because they can keep updating this tool. And it's very exciting to me that there's this big AI connected to be able to find all these regulations and rules. Okay, so let's go ahead and jump into the case study. I'm not doing any history today because we've got so much to cover. So here's the case study, and Deepak, you had brought up this case study and everybody, if you're not familiar with the room, there's a Q&A box and a chat room. Please enter your questions and comments as we go along. We'll be happy to do that. We are going to get to, I had questions about it before we started, about the new MCG guidelines, and yes, we are going to put those up and show them and show you how to get to them and talk about how they apply now. So Deepak, this is your case study.
All right. So Ernie, while I read the case, try and help Jamie and Maria to get on. I think there's some back-end settings. There's too many settings for going on, but try and get them on. But the reason we were having this discussion, and let's roll back another slide.
Sorry.
The reason we're having this discussion is with these new regulations coming on, we had the impression that COVID-19 was going to be a slam dunk inpatient. Unfortunately, that is not happening, and the number of waivers of what the payers are doing, what Medicaid is doing, there is a whole bunch of auditing that they may perceive to have paused, but that is clearly not the case. This is a real peer-to-peer we did about 12 days ago. I agree, 12 days in this time and age almost seems like a decade ago in terms of what people are understanding. But I think for the benefit of our participants who read this case, I think everyone would be able to imagine this is COVID-19 with a critical prognosis. So 51-year-old male comes to the ER, chief complaint of 5-day history of shortness of breath, mid-sternal chest pain, fever, abdominal pain, diarrhea. So classic COVID of what we're seeing. Pressures are okay, but tachycardic at 100, respirations at 13, and then febrile at 1 or 2.7. Pulse ox is 93% on room air. Now, people who are following COVID have noticed that there is a permissive hypoxia that COVID patients are being on. And lungs initially were clear to auscultation bilaterally. Now, these are all ER notes, and we'll talk about when to follow through on ER notes and how, what is the T-half or the half-life of a ER triage node, and how much more can be followed on day 2, day 3. But in this particular case, sodium's low at 131, potassium's 3.1, white count is 8,100, and hemoglobin 15.8. Let's scroll down. Our ABG is a pH of 7.52, PCO2 of 30, and PO2 of 61, and this is on oxygen via nasal cannula. The SARS-CoV-2 PCR is detected. Chest X-ray is showing bibasilar infiltrates. Ernie, I think the slides are advancing. Let's.
Sorry, I was trying to.
Yeah, let's roll back.
Okay.
So chest X-ray is the bibasilar pulmonary opacities, the interstitial alveolar space opacities, and the CT scan of the abdomen and pelvis. Don't show any abdominal process, but the ground glass opacity. So what we have learned from data from China, from Spain, from Italy, it fits with what this patient had. The diagnosis we put in is acute respiratory failure, community-acquired pneumonia, and then COVID-19. So let's advance the slide now.
Okay.
Now this patient gets treated, we get ID on the case. There's plaquenil, cefepime, azithromycin. Our diagnosis is respiratory distress syndrome, hypoxic respiratory failure, acute kidney injury, COVID-19, and then electrolyte issues. And documentation on the discharge summary says patient was kept until he was non-febrile for greater than 48 hours with extensive counseling on self-quarantine. Now, this is a patient with very poor home resources, small house, wife had issues going on. But we received this denial saying case denied from patients transferred from the ICU to a monitored bed. So the last 2 days have been denied and a peer-to-peer has been scheduled. And when we had done this presentation, the peer-to-peer had not been done. However, it took us about 35 minutes during last week's peer-to-peer to finally convince this Medicaid plan for Illinois, the medical director for a Medicaid plan, that this is what we thought this case should have been approved as a full inpatient. Our question when we received the case and what triggered this EPAS discussion is, well, is inpatient appropriate at presentation? How long do we keep the patient in the ICU? How long do we keep the patient in the hospital? And then when is the patient really ready for discharge? Now, one of the things that we had checked with John, who's Aerolib's chief regulatory officer and attorney is, can these plans actually do this? Can they deny this? And I think, John, once Marina's done with her portion of inpatient and how long we keep, and Priyanka's done with her criteria for discharge, I want people on the call to think is once all these waivers are in place, does this mean everyone is free to do anything they want, whether it's the hospital or whether it's the payer? Because I think the message is quite unclear on when CMS and the payers say they won't be auditing. I think they have put the 3 dots left saying we won't be auditing, but we can do 1, 2, 3, 4, 5, 6, and 7. And I think that's where physician advisors from Aerolib as well as on the attendees want to know is, hey, how good are these waivers? How good are these new regulations? So let's move on, and for the benefit of all the listeners, we'll be answering these questions as we move on.
Okay.
Now, this is not ours. This is Dr. Mark's one-pager. And again, this is available on pretty much all forms of social media. We are part of multiple Facebook groups for COVID-19, and we pull this out from there. A lot of the information on this is not new. I think by this time, everyone on the call, every practicing physician pretty much knows what the biology is, what the epidemiology is. The fact that we're looking for lymphopenia, acute kidney injury, liver issues. I think one portion that he had, when this was made, he hadn't put on is the myocarditis and the cardiac manifestations. I think the new ones from yesterday also show cutaneous manifestations. So COVID seems to be affecting almost every organ. But again, this is free for available. I think Dr. Mark has been kind enough to share it with us. So feel free to use this from the slide deck if you don't have this. Ernie, let's move on. And I think this is where, Marina, you had spent a lot of time because there was just so much new information in the last 48 hours. Do you want to take it on from here?
These slides are driving me crazy today. I don't know why. There we go. Okay. All right. So the one thing we did want to say before I get to Marina's slide is, remember everyone, this is all this was edited just before we got on today, so it's as accurate as we can make it right now. So just keep that in mind.
So guys, I hope you're able to see this slide fully. And before we go into new recommendations, what should be patient observation, I think it's important for us for clinicians to understand what is actually clinically appropriate guidelines for deciding to bring the patient to the hospital, either OBS or inpatient. And I found that University of Washington has done a fantastic job in putting out recommendations to all providers across QS on how to deal with these patients. And I haven't been prouder to be University of Washington alumni than I'm today. As you know, Washington was hit pretty hard by the first cases of COVID-19, so they were forced to, figure things out and educate all of us on this disease. But basically, when you clinician, when you make decision to bring this patient in the hospital or not, you're looking at 4 factors. Number 1 factor is vital sign admission. where the patient is hemodynamically stable and where the patient is hypoxic. And the definition of hypoxia is much more lax than typical definition, so to speak. We're looking at pulse ox less than 94% versus 90%. When I read about COVID-19, when I talked to my friends and colleagues who are taking care of these patients, they all said the same things, that it's beast-like, unlike anything they've seen. Patients who crash and burn, they can do it suddenly and unexpectedly, and when they crash and burn, they get really, really sick for a long period of time. So the threshold for admissions to the hospital and the threshold for admission to ICU, it's much lower than for other respiratory infections. So the second criteria you look is general risk factors, and they are on the square bottom on the left side is age, comorbidities, underlying immune deficiency, altered mental status on admission, or evidence of low respiratory infection. The third factor you look in is try to identify those patients at risk for crushing and burning, the risk factors for progression to severe disease. And you've heard of them. It's elevated D-dimer, CPK, CRP, LDH, worsening creatinine from baseline. It's abnormal function test, elevated troponin hemoglobin. We all know about absolute lymphocyte count, elevated lactate, extensive bilateral infiltrates, and another key is 1-minute walk test. If patient is unable to do it, or if patient's oxygenation was 90%, that's sure indication for admission. And the fourth factor to make that decision is whether that patient can be safely isolated at a low level of care. So when you put these four factors together, the decision tree is not straightforward, but it's a little bit easier again. If patient has stable vitals on admissions, there's no risk factors for progression to severe disease, and then patient can be reliably isolated and monitored at home, that patient could be discharged home. If patient has unstable vitals, right, if somebody has pulse ox less than 94% requiring oxygen, then decision tree is how much oxygen they need. They are on 5 liters and still saturated less than 94%, that ICU admission. And in DPAC, your patient, again, somebody who came in with pulse ox of 93% and then has AO2 of 61 and 30% of IO2, that guy has a bad case of COVID, right? That guy clearly needed to be admitted to ICU, and I'm glad he was admitted to ICU. Then there'll be some patients who are moderately sick. Again, they require oxygen, but their pulse ox is than 94% or less than 5% nasal cannula. I think it's appropriate to admit those patients in the hospital. Where the gray area is, and that's the second box from the left in dark gray, when you have someone who has stable vitals, right, but who has some either underlying risk factors or risk factor for progression to severe disease, what are you going to do with those patients? And I suspect that a lot of these patients will be appropriately admitted to observation initially until we see which direction they're going to go. Again, this is a sort of clinical indication for bringing those patients in the hospital. And then MCG has done something timely and interesting, like literally 4 days ago. They actually, and that's the next slide, they actually issued some guidelines on COVID-19. And the recommendations is twofold. They recommended using existing guidelines and even highlighted what's sort of the most appropriate part of these guidelines, what's most applicable to COVID. And honestly, I found that there's some conflicted information, and if I have to use any of these guidelines to, make for my concurrent reviews or make arguments for my appeals, I actually found that the most helpful is pulmonary disease. Ernie, it keeps jumping. Pulmonary disease, specifically a subset of guidelines that deals with high-risk pulmonary infection. Let's take a look at that. Specifically, again, if somebody has temperature more than 103, if somebody is immunocompromised, have history of severe COPD, severe CHF, or uncontrolled diabetes, cirrhosis, these patients meet inpatient criteria. So again, I intend fully to use this pulmonary disease general recovery guideline to support my cases. And then Millman also, MCG, also developed 6 new acute viral illness guidelines. There's a one OPS guideline, There's the two inpatient guidelines, one for pediatric patients and one for adult patients. There's the two home health guidelines, one for adults, one for peds, and there's one recovery guideline. So that brings number to 6. And it's interesting to see how MCG defines inpatient for this acute viral illness. And by the way, they're not part of the web version. Updated version was just released about a month ago. But if you click on this COVID-19 resource page, you can actually download these guidelines in PDF format for free.
So I have a question for Maria. We see you looking great. What are your thoughts on what MCG just released? What they've come out is not what's unknown to us, right? We've known the clinical medicine. I think a lot of the discussion happened on what they classify as an inpatient observation, and I think you're putting on the chat box. It depends on clinical stability. So talk to us a little about this MCG issue.
So I think, what Marina had shared earlier, that graph about, who to admit when, maybe a slide or two behind, Ernie, the graph that Marina had shown, that I believe is truly the best one, this one, exactly. When is it appropriate for inpatient? What we have found is if you follow these guidelines, the payers on the other end are more acceptable for an inpatient if they're meeting those guidelines. So like Marina said, one of the things we saw very different in this viral illness is the fluctuation of a patient. They could be, stable on day 1 and they're crashing on day 2. Or we are ready to send them home and then they crash. So the fluctuation is very dramatic for these patients. And so trying to ensure that these particular patients are you sure about their COVID status? The testing is important. Finding those tests is really important. So you have the test, you have the presentation, and that's when you're chatting with the payer to figure out whether it is inpatient or not. MCG, it is very helpful when you're having that discussion, but our discussions are truly more retrospective after we've had a lot of that information. It is not done on day 1. So that is important from our perspective, Deepak.
Yeah. And then, Jamie, what are you seeing from these new MCG guidelines that have come up? And, how relevant are they right now?
Yeah, do we should take a look at those guidelines before we continue discussion, because I just want to go on the page about what we're talking about. So again, this is a viral illness for inpatient, and basically it falls into sort of 3 reasons why a patient can be inpatient. One of them is pulmonary manifestations, and they're here. And I think where our disagreement with payers is going to be, what defines hypoxemia? Because they still use pulse ox less than 90% as their definition of hypoxemia, where the us clinicians using 94 cutoff. So I think that's going to be point of the discussion. Then I think this is where documentation, especially by ED physicians and hospitalists, are the key. Accessory muscle use, severe tachypnea, respiratory destruction. I mean, if that's documented in the chart, then it makes my job as a physician advisor much easier to argue that these patients can be inpatient. Patients is one criteria. The second criteria is, you can go to the next slide.
Okay. We are getting some questions in the chat box, by the way.
Linda, just hold on just a second, and I promise we're going to answer these questions. And then there's systemic manifestation. They're right here. And the last interesting piece of criteria is isolation that needed to be, the basic isolation that failed observation, right? That is isolation that cannot be performed in other than inpatient setting. Again, the good documentation from attending physician is going to be the key. Why these patients could not be observed at low level of care. And one thing more about COVID-19, and I'm sure you know about that. Not only it's not widely available, not only it takes at least 48 to 78 hours to get results back. But also, even for those patients with classic COVID symptoms, 75% sensitivity, which means 25% of the patients may have negative COVID-19 tests. I think that's going to be complicate our dealing with payers as well. So again, good documentation is the key. How are we going to document it? Acute viral illness, strongly suspect COVID-19. I mean, there has to be documentation there in order for us to have, fruitful discussion with payers around appropriate status. So this is, and then observation. Again, Ernie, if you can move to the next slide.
Okay.
And these are the observation criteria for adults. Again, they're right here. The most interesting is actually going with the following slides.
All right. So, Jamie, I want to ask on a principle basis. John and I had talked about use of MCG and during peer-to-peers. John, what do you think about these new things that have come out?
Well, you know my bias against peer-to-peer discussions to begin with, but I'm not sure that new guidance from any third party really helps us in this venue. If the patient's sick enough to be in the hospital and be an inpatient and meets the requirements of your contractual obligations with the payer, then they ought to be paying it. If they don't, then you don't need to have a peer-to-peer. You need to change your documentation and re-review the care the patient's getting.
Right, and I think this is one thing that John and I and Aerolib, and we've talked this with a lot of hospitals, is if they are using physician advisors to follow MCG tick marks, they don't need physician advisors. They pretty much need someone who knows MCG. You tick mark it, and then you send it over to the payer. But the fact that despite the documentation and the check marks on MCG, you're still getting denials, it means the payers are not using any form of screening criteria as their sole reason for denial. So when these new guidelines came out, I mean, we've been following COVID since January 15th now. Nothing in the guidelines is out of medicine. All these are medicine, but it's their perception on, hey, we think this would be good. But again, it depends on the story that we paint in the ground. And a lot of times you will see, and I know Jamie will talk about this, is those paragraphs where hospitals are using saying due to the PPE shortage, we're not allowed to examine these patients. And I know, John, you had mentioned on the waivers and these new criteria, there is nothing about waiver of the quality of care. And so when you look at these guidelines, they are portions of history, they are portions of examination, they are portions of medical decision making. But if hospitals are just bypassing that component of examination under the loophole that we don't have enough PPEs, how valid are these guidelines and how valid is our discussion with the payers when these are finally in place? John, you want to talk about that? Is there a waiver of quality of care?
No, let me back up for just a second. And when we say, I know what you meant when you said when hospitals bypass these things because in order to conserve PPE, but hospitals, I am unaware of any hospitals that are actually sending out a dictate to their physicians that says, don't examine patients and conserve our equipment. That may be happening. I'm not aware of it. These are individual physicians, in my experience, that have made this decision that I'm going to conserve this or for some other reason. So I don't have any experience with the other occurrence. So I think we need to focus this very clearly on this is a physician-directed occurrence, and every physician needs to have the proper equipment. I think we would all agree with that. But there is nothing in any of the waivers that says we're waiving the components of a physical exam. We're waiving any of the components of the E&M coding requirements. We're waiving anything else.
Right. Now, Jamie, talk about what you were seeing in some of your reviews about that extensive disclaimer paragraphs on the examination portion.
Sure, absolutely. And you're right, Deepak. We're seeing this kind of across the nation with, one blank there, sorry. across the nation with hospitals and the physicians putting in these generic statements. Very often they'll say, I'm going to defer to the emergency department physician's documentation for my own physical examination. You can sort of understand when there's limited PPE why you might do that initially, but as we're seeing these test results coming back within hours, and thank goodness not days to weeks, there's kind of a very little defense for the physician to say that the COVID test was performed in the emergency department, came back negative 3 hours later, why the physical examination and the history and physical does not include their own personal examination. There's just no defense for that. And, we're missing a lot of the quality aspects of that as well. If you're not examining the patient, you're not going to identify things that need to be treated.
Right. And Maria, what are you seeing with Ensemble in the multiple hospitals that you guys are auditing?
So I would have to say that the clinical documentation is really critical. And we do not, we are seeing, I have to say, some physicians documenting that because of PPE, they're not doing the exam. But I have to say that once we do get a negative COVID test, we are moving the patients, and then they are required to then go and do the full physical exam that they had bypassed initially. That is one piece. The second piece I would say is that, to your point, Deepak, this is not a waiver on quality. And there is no hospital that is saying we have not enough PPEs today. All of this is I guess by the physicians themselves, that they're trying to conserve or things like that, and they don't want extra exposure. Many hospital systems have built teams so that one team stays in, the second team is outside, and they are, rotating their staff so that not everyone is exposed to the COVID patients. But once they come out, then they're supposed to be doing the requirement. I would like to add, though, here that a lot of docs, even in that clinical documentation that Marina mentioned, is so critical, because they may say in the progress note section that, patient is doing fine at this time. There is a disconnect, that copy and paste still exists. And if you don't see what happened overnight with the patient, the respiratory therapist or the nurse may have said that patient was hypoxic for X amount of time, was given O2, and then was brought back to room air. If that conversation is not part of your peer-to-peer, you're selling yourself short.
Or if you're not documented, actually is dyspneic. I'm not sure that if you saw the article in the Hospitalist that was about Evergreen Hospitalist experience, who basically were on the forefront of the first explosion of COVID-19 in the United States. And it's a fantastic article, and they put together lessons learned at that date on a weekly basis. And basically, their lessons learned is, don't look at the numbers, look at the patients. If patient begins to experience increased work of breathing, it doesn't matter what pulse ox says, this patient is going to crash, right? So the key documentation of increased respiratory effort, and if that doesn't exist, it's going to be very difficult for us to argue with payers around inappropriateness of inpatient status.
Yeah, and I would say Dr. Trin, one of our, has commented, from Ensemble, that he's right. Tons of waivers are available, but they're only if they're needed to bring more staff to the bedside, to reassign your staff. If they are using waivers to not do the right stuff or address the quality of care, then they're doing it at their own peril. He's 100% on the mark.
So Priyanka, Linda had asked a question, are you seeing denials, and what is your experience with the denials that we are seeing through Aerolib now?
Some of the patients presenting with mild symptoms would generally be expected to improve and be discharged, even though we might be maintaining transmission-based precautions and using PPEs. So yeah, the payers would argue that the care could have been provided under observation care. And they are partly correct, even though we are taking all the precautions, putting negative pressure, using the negative pressure rooms, using our PPEs. More resources are being used, of course. Other thing I would point out, if we are writing our appeals, is during that time, whether it's January, Feb, March, during that time, what the CDC guideline was. When you're writing your appeals, you might want to mention that. And what is your local and state health department perspective on that? What are their recommendations? Might just involve their recommendations into your chart or into your appeal letters. So that can be helpful.
Good. And John, I want to bring you in because I know I put a reminder to myself. Talk about that time and date stamp issue you were talking about when payers are releasing these new waivers and guidances.
Priyanka hit on this and hit it right on the mark. Everything that we have in terms of our data needs to be locked in and timed and date stamped. You need to build a running spreadsheet in your organization that keeps track of all of the payer information that's coming in. 3 months down the road, we are going to get massive amounts of denials for this, and it's going to be for a wide range of things because everybody will forget how terrible COVID-19 was, what it did to the economy, what it did to patients, how terrified everybody was. And nobody will care then. The payers will not be the least bit hesitant to issue the denials. And they will have the benefit of more data than any of us can possibly generate. And that data they will then use to look back and tell us retrospectively what these patients should have been based on an analysis of hundreds of thousands of claims, whereas we're seeing a few at a time. They will not hesitate to hand us denials, though. We've all seen this. They'll say this patient should have been. We all see the retrospective decision-making that they impose on us. So we're going to need to be able to demonstrate to the payers this was what other payers said. This was what our state and federal government said. This was what our authorities said. This was what the clinical experience was at that time. And we're probably going to have to aggressively pursue these cases and these claims. And ultimately, I think where most of them are going to end up is in either arbitration or a court. It's unfortunate, but my suspicion is that's where this is going to go. And it is only going to be our contemporaneous documentation that is going to save us in those cases.
So, Aerolib has a list of 10 things that we recommend our hospitals on what they need to do for patients that are inpatient. And one of them that we're telling them is take pictures of the patients. And at this stage, patients are more than willing to allow for pictures being taken. But a picture or multiple pictures over an 8-hour period speak 1,000 volumes of data. A lot of times when you're in at that particular point, when you have a picture at 8 a.m. or at 8 p.m. when the patient is prone on a BiPAP, with the other comorbid conditions happening, that's just one of the things we're telling them. And I know a lot of systems have wound care programs where pictures can be uploaded, date and time stamped pictures can be uploaded. But that's one thing that may be needed. I think the future of denials management and appeals is going to be a whole different ballgame 90 days from today. This won't be the ones that we're used to, where we can cite Harrison's principles or other clinical data. It will be a wholesome denial letter with pictures. And I know Priyanka and I, and everyone on the call should know that Dr. Fauci is the co-author of Harrison's Principles of Internal Medicine. That is technically the source of all medicine that we've learned over the last 25, 30 years. And he happens to be the number 2 after Dr. Brownbald. He's the living 79-year-old legend that we get to see daily on TV. So those are the ones that we need to follow. Ernie, let's move on. I know we've already crossed our time span, but let's move on to some other interesting slides that we had.
Yeah, these were some of the guidelines that I believe Marina had pulled out from MCG. So Marina, do you want to talk briefly about these?
That's going to be part of the presentation. Not really. We'll just focus on the discharge criteria because I think everybody is having those
Yeah,
questions.
these
All right,
things.
so Ernie,
You know,
let's move to 28. I want Priyanka to tell us when is a patient ready for discharge, because I know that was one of the questions that we had, and I know one of the people from our hospital had just asked me which patient this was. I'll reach out to them after this presentation. But tell us, when is it ready to discharge? When is a COVID-19 considered dischargeable?
So basically the CDC, this is all taken from CDC side, and what they say is that patient can be discharged even if they don't meet discontinuation of transmission-based precautions. And transmission-based precautions is basically duration of time that you want them to be under isolation precautions or using PPE. They basically say if it's clinically indicated, go ahead and discharge them. Now, if they are discharged to home, the isolation can be maintained at home before discontinuation of transmission-based precautions. But the trouble is if they are discharged to a long-term care facility or an assisted living facility, and what if the transmission-based precautions are required? And I had previous slides which mentioned until when the transmission-based precautions need to be taken. And if they are discharged to a facility, make sure that they are able to adhere to infection prevention and control recommendations. And the second point is if the precautions can be discontinued, but the patient continues to have symptoms, say, of cough or shortness of breath, then as the slide mentions, they need to be isolated into a single room. They need to wear face masks whenever a nursing staff comes in to take care of them. And they need to be under isolation precautions till all the symptoms have resolved or it has been about 14 days minimum since the onset of their illness. And if the transmission precautions can be discontinued and they have resolution of symptoms, then they do not require any further restrictions. So basically it comes down to you can discharge a patient when it's clinically indicated, when they are stable for discharge. Whether or not you continue the transmission-based precautions is a different thing. And for that, CDC has recommendations, and those are in my previous slides, which we can go at our own leisure if you want, or you can go to the CDC site as well.
Good. And I think one thing that people need to understand is once you've treated a COVID-19 with the azithromycin, the Plaquenil, with the remdesivir, or that does not mean the patient is no longer infective. In fact, data from China shows that they may still have mRNA of COVID in their bloodstream. They may still be infective. By the time they leave the hospital and are positive, the IgMs may start forming, but the IgGs aren't. And so when we are discharging someone, it's very important. And one of these points that I think one of the attendees had asked is if we could share those 10 points that we're telling our facilities. Feel free to email us at cmo@aerolib.com and we'll share those 10 points. But one of the points is what type of test you're ordering. So if you are doing the mRNA test, there is a whole algorithm on which test can be used at what time. So if you are doing that, the mRNA test prior to discharge, or an IgM test prior to discharge, there is no guidance on proof of cure because we don't know what a cure is right now. All we know is from a symptom or a syndrome standpoint, patient is able to oxygenate well, but the long-term aspects of lung damage, the long-term aspects of myocarditis, pericarditis, we still don't know that. Some of the hospitals are doing chest x-rays prior to discharge, but if you've done a CT scan of the chest at the time of presentation or within 48 hours, a pre-discharge chest x-ray may not help clinically, but again, that may be part of something that you may need for an appeal. One thing that we thought we knew, we've seen it all, is we received a readmission denial day before yesterday where the initial hospitalization was in the second week of March for flu-like symptoms, and the one last week was for sort of a pneumonia-like picture. And the discussion at that point is same and similar. I think we need to go back to CDC's initial webinar, and I think at that point 200,000 physicians attended, that COVID and flu can coexist. And so this argument from the payer saying, well, you said it was flu, now it's pneumonia, it's one and the same thing. COVID, the SARS-CoV test can be negative once, twice, you need 2 or 3 for it to be positive. But if the symptoms are consistent with what we discussed, we treat it like that. And in this particular case, the treatment protocol was consistent with what COVID-19 patients are being treated. So our argument to them is, we committed this patient as a COVID-19. We followed the treatments. We followed the utilization of contact droplet precautions. The intensity of service was there. And so we sent back for an appeal. We don't know. We'll find out in 60 days if they buy the argument or not. But we told the facility to document all these 10 things with photographs. And some of this is not clinical, but some of this is the availability. So CMS has released a burn rate Excel sheet for your PPEs. And a lot of times that's really going to be important. If your documentation says we aren't seeing this patient because we didn't have PPE or we're trying to save them, it's very important as of April 16th where your state and hospital is in the curve, what your availability for PPE is, because when we build up that 15-page appeal for these high dollar amount cases, everything will be seen, not just the fact that the patient had a pneumonia and improved with zithromycin. So there's a lot more complexity involved with appeals that are going to show up in the next few months now.
I think we have a question from one of the attendees. So how would you suggest to document diagnosis for someone who comes in with classic documentation, the classic presentation of COVID, yet COVID-19 is negative? So how would you document that to make sure that quarters code that appropriately, right? So we have appropriate DRG assignment and we have no denials. What's your suggestion?
Maria, you want to try taking that, and then we'll all try and see what our experiences have been.
Can you repeat that, Marina?
So the question is, how do you document diagnosis on a patient who comes in with COVID-19 typical symptoms, yet COVID-19 test is negative? So we need to make sure that we appropriately diagnosis, document diagnosis for appropriate coding, right? And denial prevention, DRG assignment, etc. So what's your recommendation?
So pretty much, what you had shared in the slide deck earlier, there is this, the clinical documentation, the one that Deepak, you have, I think that is slide 2 or 3. But what we have done through Ensemble PAs is that created a COVID smart phrase that is addressing all the information that we believe is important, and that is again taken from the CDC, taken from Dr. Fauci's, Dr. Bricks, all those folks that are weighing in on a regular basis that will make the documentation robust enough so that, because this is a rapidly evolving situation, we have to address all those pieces. And that's what we have developed that that smart phrase to make sure we are addressing all those pieces on a consistent basis for all our hospitalists, for all our nurse practitioners, for all our PAs.
All right, but would you document acute viral illness, possible COVID, suspected COVID, or acute viral pneumonia, likely COVID? Again, what verbiage would you use for quarters to use that possible COVID as a diagnosis?
So there's a lot of clinical information that we need, whether it is this is a person under investigation, there is a high risk factor. There's a whole bunch of pieces, and we can talk about that offline, and then maybe we can share it with our audience. But there's a whole host of things that is going to make this patient a high risk patient. Right. And those are the pieces that we need to look at.
So, Marina, it depends on what test the hospital is using. So if you have all the clinical symptoms, the fever, the cough, the chest pains, the CT scan findings that are classic for that, the ferritin level, lymphopenia, transaminases, kidney injuries, now cutaneous symptoms, now abdominal symptoms, and you have committed this patient for treatment, then it is COVID-19. The test may be negative, but again, depends on what test you're using. Now, you'll be surprised, and I think all of us, when we look at the SARS-CoV-2 test from different hospitals, whether it's an Epic or Cerner, you'll see a half a page of disclaimer saying, due to the emergency, this test has not been FDA approved, but it is a rapid test for some sort of screening. There are some respiratory viral cultures which can test for SARS-CoV, but not SARS-CoV-2, and there's a disclaimer there. So it depends on what you are defining as a positive SARS-CoV-2 test. Now, if they're testing for mRNA or IgM or IgG, that's a completely different issue. What will happen, and I think what you're seeing in the news is, when we are talking about a population health herd immunity, what we're trying to test is for the IgG, assuming that a lot of the population has been exposed, has had the mild symptoms of the disease, and they have either started developing IgM or IgG, assuming that they have been first exposed. So there is a high chance that if all of us on this call or most of the attendees who are in the hospital may have a mild fever, cough about 6 weeks ago, 8 weeks ago. We took some Tylenol and hopefully not Motrin, and over 5 days we recovered. But if we were to test the viral mRNA, that may be negative or undetectable depending on the threshold of the test. But say we test ourselves in 90 days, the IgG may well be positive without us even knowing it. So it depends on what we're testing. But if we have the hypoxia and the other clinical symptoms and you're treating for COVID, then we'll stick to COVID. Hey, we assumed it was COVID. The sensitivity of the test in our facility is 82%, which means 18% will be a false negative. But that documentation needs to go through. And I think that's what we'll be using for our appeals. I think there is a pause in the appeals, but like everyone in this call knows and every attendee knows, I think the payers are sharpening their knives right now.
Right. And Deepak, one of the other pieces I would also share is that initially, not everybody was using hydroxychloroquine. Everybody had their own way of treating this. This is only recently that people have combined zinc and hydrochloroquine, and in some cases we were using steroids, in some cases we were not using steroids. So this is a rapidly evolving, and we need to say when we are doing these denials, which they will come, at what point, with what information did we have at that particular point to do that therapy and to recognize whether it was a COVID or not.
Very right. All right, so Jamie, tell us, we're dealing with all these waivers. What is going on with these waivers?
Absolutely. And actually, I'd like to weigh in a little bit on the types of denials. So I work both on the concurrent side and also the retrospective. And concurrent denials, there's really kind of 4 categories. Unfortunately, I think we are seeing some of these just outrageous denials of the person who is on ventilator or CPAP BiPAP. I mean, they're critically ill and yet they get denied. Those hopefully are a minority. But you have the other end of the spectrum, which is the person who stays in the hospital, who has minimal symptoms, is not sick, and they're waiting for a test to come back and have a safe discharge or safe disposition. Those are the ones where the physician advisor and the UM team need to stand up and say, you know what, they can actually go home and we can free up that bed. The hard part is these middle ground patients that this is the bulk of the types of denials that we get, and those fall into kind of 2 categories. The first category is where these patients are presenting with very atypical, for us, signs and symptoms, and so therefore, if the payer is looking for a white count of 28,000 and a fever of 104, they may not see that despite the fact that the patient is at risk of rapid decompensation. So in those situations, I'm seeing the denials simply because the people looking at the case don't understand the variances of this particular disease, and we have to educate them on that, and usually that works. The next group are the ones that are just really borderline as to whether they're sick or not, and that really depends on that physician documentation of the risk. Are we capturing all those comorbidities as in terms of, are they immunocompromised? Are they at risk of other issues? Do they have heart failure, et cetera, right? So you have those four categories. The one that I'm seeing is the most problematic is where a patient is not discharged because the team feels it's unsafe to send them back to their post-discharge environment. And great, you're documenting that, they can't go until they've recovered or their test comes back or et cetera. It's like, but you're not telling me why they can't go. And that's what we need in the documentation. Why can't they go? If you're telling me that this patient who is still shedding virus is going home to a renal transplant wife, on immunosuppressive medication, and they live in a one-bedroom, one-room house with 3 kids under the age of 5, I'm going to say, you know what? Yeah, there's such a thing as a compassion that they can't go home type of thing. So it's important to know which of those you're dealing with and document appropriately for that. When we're talking about the waivers, this has just come fast and furious, and I feel like I spend my day trying to understand what the new waiver is for today. And actually, I'm heartened by this, mainly because what we're seeing is they're actually responding in real time to help us to get through this crisis. So there may be some nefarious things on the side, but at least up front, it does feel like the healthcare industry is really trying to say, let the doctors and nurses be doctors and nurses, and let's take care of people. And I like that part of it. Unfortunately, it's going to be forever trying to get this mess untangled. And, there's going to be disagreements on who should have been waived, when they should have been waived. And the biggest risk I see for hospitals are the ones that are not seeing this overwhelming wave of COVID cases coming in, saying, you know what, we have freedom to just skip having a 3 midnight stay for a skilled nursing facility in traditional Medicare. So no. You're going to have to be able to prove why the waiver could be applied to your hospital and to this particular patient. Go to the next page, so we'll take a look at this.
Here we go.
Go ahead. So we're also looking at this just massive economic crisis, financial crisis. People are hurting, not just from health, but also from the financial side of things. People losing jobs, right? Well, the insurance companies are losing money. Their stocks went down. I'll cry a tear, but they're under increased pressure because they're going to have fewer premiums coming in. People are going to be dropped from their roles. Hospitals, Beaumont Hospital in Michigan, a big hospital for us, they're looking at losing 20 to 40% of their revenue stream. And, when you're dealing with a 4% or less margin, 2% margin, 1% margin, you can't really suck up 20, 40%. And so that's where you're seeing these furloughs, laying off, and contractions. Hospitals are hemorrhaging money right now. And so guess what? The physician advisor and the UM team, we've got to make sure we're setting up the hospitals to get reimbursed for what they should be reimbursed. It's going to be critically important for a lot of facilities, and we look at the real risk of hospitals going bankrupt. But the payers are going to get through this time frame, and they're going to absolutely forget that there was a crisis and start saying, we've got to protect our bottom line, which means there's going to be this increased ratcheting up. You just know it's going to happen. We've seen it before. And so now we got this problem, right? What's difficult for us is making sure and looking at these recommendations, making sure we keep this straight. John said it. We've got to have institutional memorization of when things happen and where. I actually had an appeal yesterday where the hospital was claiming that they were late in getting a appeal in because of the COVID-19 crisis. It's like, well, guess what? The dates of service were in January, and the appeal was due in early February. Guess what? The Stafford Act was implemented, March 13th, and so if all this stuff occurred before March 13th, you're going to have a hard time arguing that you weren't able to meet the milestone. So you can't use COVID-19 pandemic simply as an excuse for why you're not doing the normal process of your if you can do that. If you're overwhelmed and it's all hands on deck, absolutely. You get patients taken care of, you do what you need to do, and then we'll fix on the back end, right?
Right. And I think, Jamie wonderfully said, I think the bottom line here is, hospitals and systems that are trying to see if UR is a necessary or essential function right now, do not let go of it. This is a very critical junction where the UR team can actually guide you and help you save or at least recoup money coming in for the next 3, 6, even 9 months. In fact, the entire year may be dependent on how your case management and UR team function in the next 30 to 60 days.
We're always looking at, as physician advisors, reading through these medical records, we always say paint a picture of what's going on with the patient. There's a big difference in how you document a patient who's going home to a large house with multiple family members that are not at risk of complications related to COVID and can support you in the home environment, and that you're clinically reasonably stable to discharge there. That's completely different from the person that has 5 comorbidities, is homeless, says in the emergency department that I'm going to leave here, I'm going to cough on everybody I run into. Those illustrate a wide range of difference, even though the patient's objective findings may be the same, and the 2 patients are treated differently. If you don't have that documented in the medical record, you can't bring that up 6 months down the line when you're arguing for these appeals of denials. And, it's just good practice to understand that, there is a higher risk both for the patient and the community in the second patient compared to the first. And are you documenting that? And is your team making sure that they're following up on these types of differences?
Well said. And I know John had talked about dating and time stamping, or at least keeping a record of these regulations and waivers. But a lot of times, one other strategy is when you are applying a waiver in a patient, make sure it is available in some part of the record that you were acting based on what your state recommendations were, what the waiver that you're applying. What you don't want 2 years from now is people forgetting what they used to make that determination as of April 16th for a patient. And that is going to be critical when payers start coming in. I know, Priyanka, you put in a payer in a state furloughed its medical directors for inpatient review. What's the inside info?
I don't know if I'm allowed to say which state and which payer, but yeah, they had a peer-to-peer for some other reason, and they did mention that they follow all the inpatient side medical directors, and they don't know yet when they are coming back. So yeah.
Okay.
Doesn't mean
Deepak, one of the things I'd like to ask the group is this thing that I've been seeing, especially over the last couple of days, and somebody mentioned in the comments section, there's been furloughing of staff at the payers as well, and even some of the medical directors have gone back to direct clinical or doing telemedicine. And so I'm actually seeing where the payers are failing to meet their regulatory and contractual obligations to get these approvals, authorizations back to us, or to respond in a timely manner. And that's just as important to document. You should really have a system in place in your facility and have your physician advisors kind of supervising that, where you're capturing when it is that you tried to have a peer-to-peer, you tried to obtain authorization, but due to the limitations of the payer and their staffing, they're coming back later and later and getting us these answers. And, if you're sitting around waiting for approval to go to a skilled nursing facility or LTAC or acute rehab, that's going to impact your facility right now, but also down the road. Now they come back and they start denying those days because they didn't have authorization.
Well said. So, John, I know we want to hear from you. What do you see coming in 30 days, 60 days, 90 days from now?
we're going to see pretty much the Armageddon of denials. All of the waivers that we have seen right now relate to some technical component of the process of moving these patients along. Virtually none of them have waived the inherent components. The classic is we're going to waive the pre-authorization to get this patient to a post-acute care. But in none of the waivers does it say we're waiving any of the requirements for that post-acute care. The issue there is that means that this patient who doesn't have to go through a pre-approval process to get to a SNF or an LTAC or get home health may down the road have those services denied. And by denied, I mean denied payment. Of course, they're not going to take back the services that have already been delivered. But that's going to leave LTACs and SNFs and home health agencies and potentially some hospitals in a situation where they're left having delivered these services, not realizing that that really just meant that we're waiving the requirement for a pre-authorization. As we look at things like the DRG diagnosis, and Maria and Marina have both touched on this, currently COVID-19 is a diagnosis of exclusion absent positive serology or a positive PCR. So what really matters there is that you have fully articulated, comprehensively documented criteria in your record that say our flu is negative, any other things that you might be able to check are negative, our serology for this, and this are negative, and oh, by the way, I don't remember who said it, we have a classic presentation for COVID, because the classic presentation for COVID is like the classic presentation for an MI. It is pretty much anything you can throw at it. So we have to be able to line these things up and then hit very carefully on the things that really, really are the things that might be conclusive, like a classic CT or a classic chest X-ray combined with the other things that are clinical findings. So we've got to make sure all that's in the record. Down the road, when those of us who are on the phone and on the line listening see these as denials, if that's not in the record, we're going to be stuck. We're just going to have to give it to them. And if our reason for admission was COVID-19, but somebody's able to penetrate that diagnosis and take that DRG, that diagnosis away from us, the rest of our admission is probably going to fall apart pretty quickly, because we're going to have to rely on did it meet MCG for some viral illness, and that's a pretty high threshold to get over. So I'm just going to encourage everybody to pay attention, print to PDF, and document everything that you see from your payers, because we used Trailblazer as the example. Once Trailblazer decided to take stuff down, their entire website disappeared. So you need to make sure that you've got all that locked in and saved in an appropriate fashion, because 3 to 6 months down the road, when the payers finish their analyses, they're going to look back and say, we've got some margin to make up here, guys. And they're not going to want to erode that, and they have shareholders that are going to be looking for returns. So we're going to have to be able to manage all of this downstream, and it's going to be aggressive.
You all need to remember that payers don't have the same values that you do. They make decisions based upon their values. You make decisions. Your hospital makes decisions based upon your values, right? Do no harm, right? First, do no harm. Payers don't have that same value.
Well said. Very well said. And I know we're waiting for Maria's points, but I do want to tell, people who are listening, use Aerolib Cerebral. It gives you the citations for the waivers. Take those screenshots, add them to your patient record, or somehow link them that's what you're using. It will save you a ton of headache 6 months from now, a year from now. It is something that, and again, I can't thank IBM enough for allowing us to work with them. But just please use it. It'll save you a lot of headache later.
Yep.
I think so. So, we started off thinking this would be a 30-minute show. This is our third discussion amongst the Aerolib team, and we've already spent, I think, an hour and a half in the first discussion, hour and a half in the second one, and we are way, way above than what we thought it would be. But Maria, we want to know your KFC points.
So one of the things that Deepak, who is our sponsor for this show, said that when you listen to 1 hour or 30 minutes, whatever it is, of this EPAS show, you should be able to leave and do something right away, something that is actually applicable as soon as you finish listening to us. So when I listen to the experts on this call, for me, I need to know what is my COVID census, how many of my patients are COVID, what is that kind of documentation that, is required for those particular patients. Do I have 1 or do I have 20? Because that is going to be important. How many isolation beds, all those kinds of things are important for me to know, because this is the high-risk population today. So we want to find and focus on our compliant documentation criteria. A lot of this was shared today. And if you email Deepak, he will be able to share those 10 tips that he's willing to share with you all. That's important. You have to find your recipe that you can consistently share with your hospitalists and your UR team. And then clarify from your perspective and your denial team, which payers are denying, what is their response, are they available to take any information from you and give you those pre-certs, those authorizations, so that you can discharge the patient to the SNFs or home care or whatever it is that you need from them. If you don't know what the problem you're having today, you can't fix them. So know the problem, and then you can find your solution. Back to you, Deepak.
Wonderful. Ernie, all yours.
Okay. Well, we've obviously gone over, but everybody who's registered will get access to the recording as well as the slide deck. We will send that to you, or we'll have a page. We haven't really decided how we're doing that at the moment, but we will get something to you. I'm imagining that we are going to probably do some more about this, because I don't think this is going away anytime soon. So, and I do have Finally Friday shows coming up. There will be probably more than usual coming up, and those are always free as well. So everybody, you'll be able to get access to this. There's a document in there, and I created slides about some of it that were created by Dr. Chadha, Priyanka, and where she put together some scoring tables, and a lot of the information that you've already seen is in that document. We'll make that available as well. So at any rate, there's plenty of good material coming up, and we will make it available. Reminder once again that Aerolib has a complete set of services. If you find yourself in need of some, in particular, physician advisor services or help with your physician advisor programs, this is the way to do it. So all of you, thank you for spending your time with us today. We, of course, owe thanks to the 6 physician advisors we had on today, and some of the ones participating in the chat box and the Q&A box. Thanks, everyone. We will let you know again. Please share the links to our pages and shows with your colleagues, and we will see you next time when we continue our journey to empower physician advisors. Thank you, everyone, and bye-bye.
Bye-bye.
Thanks all, guys. And to all the listeners out there, hats off to Ernie for just a wonderful slide deck. I know this is version 7, Ernie, and we've been sending you material every 3rd day, but just a beautiful slide deck. So great work there.
Okay, thank you. Thank you all of you for giving me good stuff to work with. Okay, bye-bye.
All right, guys. Bye.
Bye-bye. Stay safe.
Bye.